We've got Susma Vaidya, I'm close, yeah, from Children's in our general pediatrics and our ideal program for kids with overweight. And Dr. Nazrat Mirza, one of our colleagues and one of the co-authors of the guidelines, is actually in jury duty today. And actually, I kid you not, we asked the judge, to turn her loose. We got all these folks here and no such luck moving the legal system. So Susma has agreed to fill in. We're all top notch and we'll all get the guidelines out there for folks to understand. So here we go. Everyone doing okay? Temperature all right? Okay, I will pass that message along. And for the cool kids sitting in that far corner, there are empty chairs and tables here where you can sort of stretch out or whatever. So feel free, if you want to reposition, do so now or during one of the breaks.
Good morning, everyone. I am thrilled to be here. It's so exciting to see some familiar faces and to be here in person. Certainly very tired of doing Zoom conferences. So I am going to present for Dr. Mirza, who, as you heard, is in jury duty. I am sorry that you will not get to hear her in person, but I will do my level best to convey the information that she wanted to share with you this morning. I have no financial conflicts of interest to disclose. So why all the interest in the new pediatric obesity guidelines? Well, the last set of guidelines were back in 2007, and we certainly have so much more information on the management of pediatric obesity, from randomized controlled trials to comparative effectiveness data, high quality longitudinal and epidemiological studies, as well as more information on pediatric obesity prevalence. We see here, if you look at the light blue line, the steady increase in the prevalence of obesity in children between 2 and 19 years of age. The prevalence before the pandemic was 19%, and during the pandemic has increased to 22.4%. So certainly this is a health crisis that we need to address. 14.1 million children in the US are affected by obesity. And of that, 4.5 million children have severe obesity. And why do we make that distinction? Well, these children with severe obesity are the ones that are more likely to track to adulthood with obesity. And these are also children who are more likely to be at risk for diabetes, cardiovascular disease, as well as premature death. So just a little refresher on diagnosing obesity. I think it's really important to make sure that we use these clinical terms here. So in children less than 2 years of age, we can't use BMI. We can use weight for length, and a weight for length greater than or equal to the 97th percentile can be diagnostic of obesity. In the age group 2 to 19 years of age, a BMI greater than or equal to the 95th percentile is diagnostic of class 1 obesity. And then in severe obesity, you have class 2 and class 3. Class 2 would be a BMI greater than or equal to 35, or greater than or equal to the 120th percentile of the 95th percentile. And class 3 is greater than or equal to 40, or greater than or equal to the 140th percentile of the 95th percentile. The new CDC growth charts that came out this year can be very helpful because they actually have the 120th percentile bolded, so it's easy to be able to plot a patient. And it's also easier with these growth charts to see progress. So of course, obesity affects the immediate and long-term health of children, which is why the guidelines are really focused on us as pediatric healthcare providers, as frontline providers in the management of these children. And the two key questions that were posed by the authors were, what are clinic-based effective treatments in obesity? And what is the risk of comorbidities among children with obesity? and we'll be addressing these during the course of the day. So what's new from previous recommendations? We understand more fully the implications of obesity as a chronic disease. We understand the physiologic impacts of social determinants of health of obesity more completely, and we know more fully that weight bias and stigma are pervasive in society at large and in the medical community, and this is harmful and can be a barrier to treatment. We know that we should be offering treatment early and immediately, and this is a central theme in the new guidelines. We need to offer and start treatment early, and it's more effective if it's offered earlier. And there is no benefit to watchful waiting. We want to treat obesity and the comorbid conditions concurrently, and there are multiple evidence-based strategies that can be used collectively to deliver intensive and trained tailored obesity treatment, and we'll be talking about those. And lastly, there's been a lot of concern and controversy over the risk for eating disorders, and the guidelines actually address this. Children who participate in structured, supervised, non-stigmatized, non-biased weight management intervention programs are much less likely actually to develop eating disorder problems or symptoms. So it's something to keep in mind, because sometimes people have some fear about focusing on this and treating this disease. So overall, the AP states we want to do a whole child approach. The underlying genetic, biologic, environmental, and social determinants that are a risk for obesity are the foundation of evaluation and treatment. And what does that mean exactly? We want to address this as a complex chronic disease. It's often an indicator of structural inequities, such as unjust food systems, health inequities, and environmental and community factors. Genetics, obesity-promoting environments, life experiences, and structural barriers to healthy living all contribute to overweight and obesity, amongst many other risk factors. And so how do we as pediatric healthcare providers get involved? Well, the reason we need to get involved, because if we look at other chronic diseases that we manage on a daily basis, we see that obesity prevalence is actually much higher. Asthma, 8.3%, ADHD, 9.8%, and obesity we have at 22.4%. The guidelines really stress the use of the medical home as the appropriate place to be managing children with obesity. Our patients have better access, they can receive prevention and early management of excess weight and obesity, prevention and early detection of comorbidities, and then access to other local resources. So given the high prevalence and the chronic nature of this disease, it's important for us to consider the convenience and feasibility of management in the medical home. And of note, there will be prevention guidelines that are hopefully going to be coming out later this summer. So the primary care clinician is well positioned to evaluate and appropriately initiate treatment, coordinate care with subspecialists, and provide concurrent obesity and comorbidity management. And what does that look like in the clinic practice setting? So we want to start off by doing a really complete history. And that would include medical history, including pregnancy and birth history. We know that children who are the product of a gestation where there's excessive maternal weight gain, where there is gestational diabetes, are more likely to develop obesity later in life. Children who are LGA, we want to watch those children as they grow because they are at increased risk for developing obesity. Medication history, being very careful to acknowledge if kids are on weight-promoting medications such as atypical antipsychotics. Family history and social history, including social determinants of health. And of course, dietary history, physical and screen time. We need to be really assessing for depression. A comprehensive physical exam is important, including BMI, trying not to make visual determinations of health, and assessing patients' readiness to change. And we're going to be talking about the lab evaluations that are recommended, but we may want to do other studies if we see examples, for example, of PCOS or obstructive sleep apnea. These are the comorbidities that are addressed in the guidelines, and so if you look through the actual article, you will see links and information on each of these. So they do address hypertension, type 2 diabetes, fatty liver disease, dyslipidemia, depression, idiopathic intracranial hypertension, obstructive sleep apnea, PCOS, and other orthopedic complications. We know that addressing the obesity really will help to intervene and improve the comorbidities. So let's talk about the labs that are recommended. And these are different from the guidelines from 2007. Children 10 years of age and older with overweight should be evaluated for dyslipidemia. You may evaluate for fatty liver disease and for diabetes and prediabetes if there are risk factors, a strong family risk factor of diabetes, et cetera. And then children with obesity should be assessed for dyslipidemia, glucose or prediabetes and diabetes, and fatty liver disease. In the younger age group, it is recommended, or you may consider assessing for dyslipidemia in children with obesity who may have certain risk factors. And what are the labs exactly that are being recommended? So a fasting lipid panel is an important test to do if possible. And the reason for that is because triglyceride levels are actually what are going to be most affected in individuals with obesity and insulin resistance. For prediabetes and diabetes, we want to do either a fasting glucose, oral glucose tolerance test, or hemoglobin A1C. In clinical practice, I think getting a hemoglobin A1C is probably is the easiest. And then for fatty liver disease, just grabbing a quick ALT. Why it's not? There, oops. Sorry. And the guidelines also reinforce the hypertension guidelines. So we want to be measuring blood pressure at every visit for children 3 years of age and older. The clinical practice guidelines also address other comorbidities in detail. There wasn't enough to generate key action statements for these comorbidities, but they do have consensus recommendations. I'm going to briefly go over them. Obstructive sleep apnea, so we should be asking all our patients with obesity about symptoms suggestive of obstructive sleep apnea, such as snoring in combination with daytime somnolence, morning headaches, nocturnal enuresis. We should be asking about PCOS symptoms, menstrual irregularities, depression in all children with obesity. We really need to be screening for that. Blount's disease and SCFE, and then idiopathic intracranial hypertension, being on alert for children who are coming in with chronic headaches. And I can tell you clinically, since the pandemic, we have been seeing a lot of kids with pseudotumor cerebri in our clinic. And so in summary, the guidelines are a pretty hefty tome, about 75 plus pages. And if you want the most salient and important facts, it's in this algorithm here. And the algorithm goes from screening to diagnosis to telling you which labs to order, and then at the bottom to going over the evidence-based treatment options. And so the evidence-based treatment options include motivational interviewing, pharmacotherapy, intensive health behavior and lifestyle treatment, and bariatric surgery. And we will be talking about those later in the session today. There are also links to other clinical practice guidelines so that you can assess different comorbidities in your clinic. And that's it. I think Alicia's going to be talking next. So Dr. Tucker is going to be talking about intensive health behavior and lifestyle treatment.